to introduce Marianne Keenan from University of Pennsylvania, and she'll be talking to us about the equinovarus foot. And escorting her up the stage is our distinguished Alberto Eskenazi from Moss Rehab. And I asked you what you will be doing. You said you'll be just here. Take care of the slides. That's okay. And I think for the other speakers, it will be easier to sit down, and then you could look at your slides because we do not have a podium. And yeah, I think it's probably easier. Okay, and please.
Thank you very much. And I also would like to thank Dr. Genet for organizing this wonderful meeting and the last one, and all the team that you put together. And it's really a delight to be here with you, even though I'm an orthopedic surgeon and I'm on the other side of the world. But sometimes we have a treaty just like here, and we work together. So you'll see on my slides at the bottom, it says University of Pennsylvania. And kind of silly, I put it that way because that's where I last worked. I'm retired now. But it should say Moss Rehab Hospital. That's really the more important thing, because that's where I learned about orthopedics and neuro-orthopedics. Well, it's not orthopedics, I didn't do much, but rehabilitation for neurologic patients. And that stimulated my interest. And then after spending time in Los Angeles at Rancho Los Amigos Hospital, then I came back to my home at Moss Rehab Hospital and continued to do a little informal consultation there. So we load it up? Okay. So as suggested, I'm going to sit. So I'm going to talk to you today about reevaluating the surgical options for the correction of the equinovarus foot deformity, and try to think about both the long-term and short-term indications. Okay. One slide, Master.
I'm trying.
I always am happy to see Dr. Eskenazi in a meeting, because no matter what gets fouled up with your audio visuals, he can fix anything. So the equinovarus foot is the most common thing that we see. And it makes standing and walking very difficult. We've learned that the deformities are caused by multiple muscles. And as you know, there's a marked inversion of the foot from overactivity of multiple muscles. So the advantages of a surgical approach: you have very predictable and good outcomes from the surgery. It gives you a permanent result so that you don't need to have continued nerve blocks and so forth. No offense to most of you here. And tendon lengthening will treat both the static contractural component of a deformity as well as the spasticity or dynamic part of the deformity. And then you can do tendon transfers as well, so that you can rebalance the forces across the joints or in the foot. And the surgery is actually technically very easy. The decision making, as you know, is complex, but the surgery is fairly straightforward. And that's good, because a good surgical procedure is one that any orthopedic surgeon can do who has a reasonable competency. It's not like you need to send your patients to one place in the world, to the big professor who needs to do the surgery. This can be done by everyone. All you have to do is convince your orthopedic colleagues to be involved. Now, the disadvantages of surgery are that it's a permanent result. So you better get it right in terms of your decision making. The recurrent deformities now are very rare. The orthopedic treatment before was not well thought of because there were recurrent deformities. But now, since we have all these new evaluation techniques, that's less common. The problem that I still see most is that people don't correct all the deformity at one time. They try to be conservative, and they'll say, I'll just do the Achilles lengthening. I'll just do something with the tibialis posterior. But then you have all the other deforming forces that remain, and so that's when you get recurrent deformities the most. So go through some of the evolution of the treatment. And as I said, the improvements in evaluation are probably the most important things. So going back to polio, actually, that's when a lot of these tendon transfers were developed. And for the, it was relatively easy to do the assessment and to regain balance. So when these techniques were then brought to the spastic patient, they would transfer the tibialis anterior. First of all, they would operate on the tibialis posterior most of the time, and it didn't work because that's not usually involved that much. Then they would do a transfer of the tibialis anterior to the dorsum in the midfoot. But since you had spasticity, and since surgically you had to be careful about not interrupting the neurovascular structures at that level because they're very close by, you would, if you were offline, you would get still some varus or valgus, whatever. So then Dr. Jacqueline Perry said, well, let's make this more predictable. And so that's when she developed splitting the tibialis anterior into two portions, putting one arm to the lateral side of the foot so that you had balanced pull. And again, it was very predictable, so any orthopedic surgeon could do it. Gait analysis then became extremely important in dynamic EMG, and that's when we really began to have some understanding of the deformity and the multiple muscles and forces that were contributing to it. And we found that the tibialis anterior was usually the most important muscle for giving you a varus deformity, unlike the tibialis posterior, which sometimes was contributing, but not as big of a factor. And as you can see here, these are almost all these cases I've done with Dr. Ashkenazi, so these are Dr. Ashkenazi's slides and it'll pictures. And this was one patient who was very interesting that we saw. And obviously he's got very severe equinovarus feet, but one was caused primarily by the tibialis anterior, the varus, and the other one, the tibialis posterior. So it shows us again just how important it is to have that more sophisticated understanding and ability to evaluate the deformities, because your approach, whether it be non-surgical or surgical, the results will depend on that. So now we have the tibialis anterior procedure, or split transfer, or the splat. And that's a term that really works well for the orthopedic surgeons. We're going to do a splat. And then the split tendon, as I said, gave you a very predictable balance in the foot. So it was done for the correction of the forefoot deformity, and the lateral arm was placed in the cuboid bone. So then it was a very successful surgery, but we had some fixation problems with that. In putting the tendon into the cuboid bone, the cuboid is very cancellous. It doesn't have a strong cortex. And so we were making a tunnel in the cuboid bone by putting 2 drill holes and then passing the tibialis anterior underneath of that. And because the bone was weak, especially if the patient has been walking, sometimes you would break that bony bridge. And so your bailout procedure, or parachute procedure, we would call it, is to then take the tibialis anterior and attach it to the perineal muscle. But tendon-to-tendon transfers or healing is slower than if you can do tendon to bone. So it worked, but wasn't quite as good. So now we have a new fixation technique. So we use the interference screws that were developed primarily for ACL reconstructions, and it's a screw that goes into the bone with the tendon and will hold it in place. And it takes very, very little incision. It's only a little bit bigger than some of the things you do percutaneously. You just need a small incision, put a suture in the end of the tendon, 1 drill hole, pull the tendon in. You have a suture in the end of the tendon, just use a long needle to pull the tendon out the other side. You can rebalance the foot exactly as you want to, and then this interference screw is placed into that bony tunnel so it holds the tendon, and you just cut the suture off the other side of the foot. So it's very quick and very, very dependable with the fixation. And then treatment for the equinus. Achilles tendon lengthening, which originally, as described by Dr. Hoke, was to make 3 cuts into the tendon, staggering them so that you could push on the foot, then have the fibers lengthen but still be overlapped. And this is still good for a very rigid contracture. The problem is it gives you a lot of weakness. And so we're taking a muscle that was already weak. People think it's strong, but it just can't relax, but it's still a weak muscle. And with the lengthening, we've made it weaker. So the preferable thing is to do a myotendinous lengthening. And this is showing how we lengthen the gastrocnemius and soleus muscles proximally in the calf just by cutting the tendon, leaving the muscle belly intact. You get the correction that you need, and it's retain a lot of the strength. So then the next thing that we would see, it keeps on going and going here. We would have the foot in a plantigrade position, but then the patients would be complaining about painful toe curling in their shoe. And so then we said, well, you know, we've been releasing the flexor digitorum and flexor digitorum brevis, longus and brevis, and that still didn't help. So then we decided that the intrinsic muscles and the short toe flexors were contributing to this. So our next procedure that we added on to the series here was to do a lengthening, a release of the tendons right at the base of the toe. And again, very small incision, and you've released the tendon, have a problem, correct the problem. Then we said, well, what can we do about the calf weakness, no matter how we lengthen the gastrocnemius and soleus? We said, well, we've released the long toe flexor tendons. Why let them just sit there and not do anything? So we attached them into the os calcis. And initially, I was transferring both of the tendons. But in that situation, you would sometimes have too much pull and have recurrent equinus. So we ended up just doing a transfer of the flexor digitorum longus. And I chose that muscle because it has a nice long tendon and it's more easily accessible, so that there's less chance of any complications. And again, just multiple small incisions. I keep emphasizing these multiple small incisions since I'm with all these people who are doing percutaneous procedures and nerve blocks to show you how minimally invasive the surgery is. Okay. And we also saw that after doing the transfer to the os calcis, that then 70% of our patients were able to walk brace-free. Because we'd be happy saying, oh, now look what good a job I did. And surgeons always are talking about, wow, what a good job I did, and complimenting yourself. But the patients would come back and they say, they don't really care that their foot's straight. It's like, I still need a brace. Can't I get rid of the brace? So we got 70% of the patients then walking without a brace. Then the next thing we saw was hyperextension of the hallux. And the hallux was then seen to be contributing significantly to the varus posturing of the foot. And it hurt. The toe would be pulling up and rubbing on their shoe, pushing on the shoe. And the thing is, you usually didn't see this unless you had the patient walking barefoot, and also, if it wasn't immediately obvious, have the patient, while sitting on an examination table, flex and extend their knee, and then you would see the hallux. Let me go back one. That's right, this one. Thanks. So we had another transfer to the procedure, and we would take the extensor hallucis, transect it, and then put that into the dorsum of the foot, just putting it into the medial cuneiform bone. And again, very small incision, secure it with one of those interference screws. But when you release that tendon, then you'll have a droop of the great toe. And so it's very important to do a tenodesis and secure the distal end of that tendon so that the toe isn't dropping down in a paralytic type fashion. Very small incisions, as you can see here, suture in the tendon, small drill hole, pull the tendon through, put the screw in, cut the end of the suture off. It's an absorbable suture, and you're finished. So you can do all these procedures in 30, 45 minutes at the most. So really get very predictable result. Let's go again, thanks. So looking at the results of our surgery, this was study done way back in the day when I was a fellow at Rancho Los Amigos. And it's retrospective. We looked at 54 traumatic brain injury patients, 59 equinovarus feet. All the 59 feet were treated surgically. 33 of the patients had preoperative gait studies with EMG, and that was in part just by location of where I was practicing, and that was at Rancho Los Amigos, and Dr. Jacqueline Perry was one of the pioneers in gait analysis. But this, again, was a retrospective study. And after the surgery, all the feet were corrected. All the feet were in good position. And there's only one complication. This was when we were doing larger incisions and having the trouble with the cuboid bone laterally. So we had one patient who had some skin slough on the lateral side of their foot, which healed with non-surgical problems. And you need to remember that the skin on that side is very thin and there's very little subcutaneous tissue, so that you're more likely to have a problem if you're lifting up a flap to do the tendon transfer. So then more recently, again with Dr. Ashkenazi's major input, we were trying to evaluate the impact that gait analysis has on your surgical planning for the equinovarus deformity. So prospectively, we looked at 36 consecutive patients and had two surgeons evaluating the patients, myself and a younger colleague. Younger colleague was trained in neuro-orthopedics, so he had experience, but not as much as I did because I was older. So we would see the patients. We had a sheet made up, and we had all the possible muscles that could be contributing to the deformity, and we would check mark. I would not do anything. I would do a complete release. I would do a lengthening. I would do a transfer. And independently, we would see the patients, and we would put down our opinions on this, and then compare the clinical exam. We would send the patient to see Dr. Ashkenazi, have their gait studies performed, see the patient back, and by the time the patient came back, we forgot what we said the first time. So we did the same thing again. Evaluated each muscle, now with the information clinically and with the gait study. And we found that, and we would formulate a new surgical plan. Then we compared the results. And again, this was done independently. And we found that, I was surprised, 64% of the time we changed our surgical plan. But the agreement between the two surgeons increased significantly. And there's no difference between the old lady and the young surgeon. We had correction of the deformity in all patients. But the problem was that there was no control group, meaning that we didn't have a series of patients that we could compare that didn't have any of this evaluation and still had correction. Because even that earlier study from Rancho Los Amigos was, 33 of the patients had gait analysis. So I think this brings us to some important discussion points. Our clinical assessment has improved significantly, drastically, with gait analysis. And then also the gait analysis helps to make us understand the deformity better clinically so that you know what you're looking for. And that really helps to, with the understanding. Surgery gives you a very predictable, good outcome with the foot being balanced. The surgical techniques have improved significantly, especially with the small incision tendon securing. But we need to start thinking about what the indications are for each individual tendon. And we kept adding procedures. Remember, we started off just with the Achilles lengthening, then we added the splat, then we lengthened the posterior tib, and it just, kept adding. Was that smart? Were we creating either deformities or weakness from adding on all these procedures? So we need to compare issues of delayed or no surgery. If you're just taking an equinus deformity and you're doing casting, blocks, having the patient walk with physical therapy on a valgus, on an equinovarus foot, then you can get stretching and getting valgus foot because in trying to push the ankle and foot up into a neutral position, the subtalar joint is more flexible than the tibiotalar joint. And so, you're getting most of your motion at the subtalar joint. So many times we're creating a valgus deformity. If we did a release or transfer of the tibialis posterior tendon, then you lose an important muscle for the support of the arch of the foot. And you looked at the patients long term, and they would have a valgus foot. So then that raised the question of, gee, if I really need to transfer or completely release the tibialis posterior, maybe prophylactically at that time, I should just do a subtalar fusion. See, we always want to add another procedure. And now it's even more important that we look at how do we combine surgical and non-surgical treatment. I don't like to call surgery non-surgical treatment conservative because I strongly feel that sometimes the most conservative treatment is just to go fix the foot with surgery. So I get on with it, is all I'm saying. Go home and get on with it. So I think we need to consider the timing of treatment of the deformity, the other deformities as well, whether or not it should be treated non-surgically and for how long and watching for what complications. And should we also be looking at combinations of treatment? And how do you put both of our expertise together? Because I really think that there are times when if you do preoperative blocks, that it not only helps with the surgery, but I think it helps postoperatively with the pain. Because you do surgery, even with small incisions, it hurts. You increase the patient's tone, and it can be very painful in a cast and for a while. So if you can get the muscle relaxed before the surgery, I think that significantly reduces the pain and even further protects your tendon transfer while it's healing. So I think these are some of the biggest points when I was thinking about it that we should, I think that's the last one. So gait analysis, again, Dr. Eskenazi's laboratory has really improved our clinical assessment. I think we still need to understand is it absolutely necessary to get a gait study? Because in many places you can't get it. And one of the things I still hear from my orthopedic colleagues is, well, you can get a gait study. We don't have a gait study. And what are the indications, both for the gait analysis and for the surgery? So the final thing is, I think we need some long-term outcome studies because we haven't been, to my knowledge, looking at what happens with this patient 20 years later, with the weakness, or does it stay good with the balancing of the tendon transfers. And one of the things that comes to mind is I had a patient who had a traumatic brain injury and came to see me, and it was 10, 15 years after his surgery. And his complaint was, look at my, I have this problem with my foot. Look at my foot, And he forgot he had seen me before and that he had surgery. So, pretty typical. So I had him walking, and I thought, gee, his foot looks really good. What's he complaining about? And they said, see, look at this, look at that. And luckily, I had taken a photograph of his foot. So I showed him the photograph. I said, this is how you were before. He said, oh my God, oh, what a wonderful job you did. I didn't know I was that bad. But clearly he still had problems, that he perceived that I didn't. I looked at him walking, I said, he's walking pretty well and his foot looks good. But he didn't feel as though it was that good. So we need the long-term studies, and we need to be more sensitive to what the patients are telling us. And rather than as a surgeon just saying, look how good I am. So anyway, so I think these are some of the discussions we need to have. Thank you very much.